Well, here we are back with our three-part series on Chapter 46 and Patients with Special Challenges. It's really essential that, sometimes in order for us to provide the best care for the patients that we're taking care of, sometimes we have to adjust how we communicate, we assess, treat, and transport certain patients. These adjustments may be needed for patients with chronic medical conditions, sensory impairments, as well as cognitive or emotional disorders, and then that group that has these other special and unique challenges. According to the CDC, there's a shocking 17% of children aged 3 to 17 that have one or more developmental disabilities. And we're talking about disabilities like ADHD, autism, as well as intellectual or developmental delays, because these things are becoming more and more common. Patients with complex medical conditions and invasive devices are now often cared for outside of the hospital setting. In 2016, there were a little over 7 million patients that received treatment in settings like long-term care, skilled nursing, hospice, residential care, adult daycare, and even home health. This shift has led to more EMS calls for transporting patients when they need acute care. Many life-sustaining treatments, such as mechanical ventilation, IV medications, are now managed at home by patients and their families. EMS is frequently the last resort when patients can't access health care in other ways or when home care efforts begin to fail. This is why it's really important that we pay close attention to the possibility of caregiver abuse and neglect, because so many providers are running on patients like these. It's essential that we recognize the signs and the clues that may be suggestive of abuse and neglect in this patient population. So there's some general strategies that we can take, or general approaches that we can take when we're dealing with patients with special challenges. Patients and caregivers are often very knowledgeable about their specific condition or impairment, so it's really important for us to keep them involved. And we should keep this in mind. So listen carefully and show confidence when asking for the patient or caregiver's input. Allow them to be that expert in the room, because most oftentimes they are. In many cases, patients and caregivers know more than the EMS personnel do about that particular condition, the medical devices that they use, and the treatment techniques that they're undergoing. Helpful resources are going to include online medical control, electronic medical references, and the experience of some of your coworkers as well. So let's talk about how poverty is going to have an effect on the EMS healthcare system. EMS providers and emergency departments are frequently on the front line of dealing with the economic and healthcare crisis in America. According to the U.S. Census Bureau, there's almost 12% of people in the United States that live in poverty. Poverty is determined by the number of people in a household, their ages, and the household's total income. A person's ability to access healthcare and related services has a direct impact on their overall health. Health disparities occur when limited access to medical care causes higher rates of illness, injury, disability, or death in certain groups. Chronic medical conditions often require continuous medications and follow-up care. Some patients may not receive the needed care or medications due to poverty or lack of insurance. People may have to choose between paying for medical care or meeting their basic needs like food, clothing, or housing. Missing or stopping medications can lead to serious medical problems, and it's not at all uncommon among this group. Economic hardships, such as job loss or drained savings, can result in the loss of access to health care. On any given day, more than 500,000 people are homeless in the United States. Homeless individuals have a much higher rates of physical and mental illness compared to the general population. Over half of the homeless population is older than 50 years old. Homeless individuals are at high risk of infections due to factors like injecting drug use, unprotected sex, past victimization, mental illness, and incarceration. A 2017 study in Los Angeles found that 27% of homeless participants tested positive for hepatitis C and 4% tested positive for HIV. In contrast, less than 1% of the general public tested positive for either of these diseases. EMS and emergency departments are often used when chronic medical conditions worsen or when no other care options are available. Federal law requires emergency departments to stabilize anyone experiencing an emergency or in labor, no matter their ability to pay or not. This places a significant strain on emergency departments, draining both financial and staffing resources. EMS crews may need to transport patients longer distances to find open emergency departments or face delays when transferring care due to overcrowding. Some patients may call EMS to get a free ride to the hospital or skip the wait in line in overcrowded emergency rooms. Even when other care settings might be more appropriate, paramedics must use caution to avoid legal issues when deciding where and how to transport these patients. Government agencies and private organizations offer free and low-cost health care through community-based facilities. Many vaccines are available at little or no cost through these programs. Hospitals often provide financial assistance, payment plans, and other affordable healthcare services. Hospitals may also help eligible individuals enroll in government insurance programs. So let's talk a little bit about the abuse and neglect factor when it comes to patient care. We've briefly touched on this, in a couple of other sections. I know in the pediatric section and the geriatric section, we'll talk a little bit more about it here. So caring for patients who may be victims of abuse or neglect can be quite challenging due to their emotional state, some legal issues, and some regulatory concerns that might be present as well. The presence or involvement of a possible abuser can make the situation much more complicated. Certain groups are especially vulnerable to abuse by caregivers, including children, dependent older adults, and adults with medical, cognitive, or emotional impairments. Millions of cases of abuse are reported each year in the United States involving children and vulnerable adults. Most of the time, the abuser is a family member. Abuse and neglect happen across all races and socioeconomic groups. Anyone responsible for the care, custody, and control of a patient can commit abuse. It can be hard to determine abuse or neglect when factors like poverty, religious beliefs about treatment, mature minors' autonomy, or victims' emotional and behavioral disorders are involved. Physical abuse is an intentional act that causes injury or physical harm, such as throwing, hitting, striking, kicking, burning, or biting. Physical abuse can also happen when a caregiver puts a vulnerable person in situations that create risk or harm. Neglect is about 4 times more common than physical abuse, and neglect occurs when caregivers fail to protect a person, leading to harm to their physical health or mental well-being. Signs of neglect are often subtle and require careful observation in order to be able to recognize them. Sexual abuse and exploitation include sexual contact, forced prostitution, inappropriate undressing, suggestive photography, and forcing victims to watch sexual acts or pornography. About 9.3% of reported child abuse or neglect cases involve sexual abuse or exploitation. Signs of sexual abuse can include specific behavioral changes, genital injuries, and sexually transmitted diseases. Emotional abuse affects children, dependent older adults, and other vulnerable individuals. It causes significant changes in behavior, emotional responses, and cognitive function. Emotional abuse can lead to various mental health issues. Verbal emotional abuse includes ridicule, threats, blaming, and humiliation. Nonverbal emotional abuse involves ignoring the victim or isolating them from others. Many states have laws addressing substance abuse by caregivers. These laws cover situations such as harm to an unborn child caused by a pregnant woman using alcohol or drugs. They also include providing alcohol or drugs to a child or manufacturing or selling drugs around a child. Being impaired by alcohol or drugs while caring for a child or vulnerable person is illegal. Driving intoxicated with the child in the vehicle is also prohibited and illegal. Allowing a child to be the designated driver for an intoxicated caregiver is very illegal. Abandonment occurs when a child or a vulnerable adult is harmed because their caregiver does not maintain proper contact. Examples include leaving a young child at home alone or letting a child wander around without supervision. Healthcare providers have a responsibility to identify and report any incidents of suspected abuse or neglect. Certain caregiver behaviors and physical signs should help to raise some suspicion. For example, a caregiver who is intoxicated may indicate that there's a problem. Also, if a caregiver tries to prevent or interfere with the physical exam of a child or a vulnerable adult, this should prompt some concern. Do not confront someone you expect is an abuser. Always report the suspected abuse to the appropriate hotline and the emergency department physician. Pay close attention when a caregiver explains the patient's illness or injury. The caregiver's story may not match the patient's age, abilities, or medical conditions, and the story may change each time it's told. The caregiver's explanation may differ significantly from what the patient tells us as well. Sometimes caregivers admit to actions that suggest abuse, such as saying, "I lost my temper," "I couldn't get her to stop crying," "I did that to teach them a lesson." Keep in mind, some behaviors may be due to normal growth, developmental, or medical conditions rather than abuse. Always share any unusual behaviors, signs, or findings with the healthcare team receiving the patient at the facility. Physical signs that may indicate non-accidental trauma include bruises to the torso, ears, upper arms, and buttocks. Closed head injuries without a believable explanation should also be concerning. Burns that are symmetrical or lack splash marks, as well as ligature marks, can suggest abuse. Bruises that look like finger marks, shoe prints, or other familiar shapes are big-time warning signs. Here's an example of some of those burns that don't fit a typical accidental burn pattern. As you can see, these burns are symmetrical, and they involve both body parts, and things such as that nature. They just don't look quite right, not what we would typically see in a one-off accidental burn. There are some harmless physical findings out there that can mimic signs of abuse. Toddlers who are learning to walk often get bumps or bruises or minor injuries as their coordination begins to improve. And there are these things called Mongolian spots that are birthmarks that look a lot like bruises and are common in infants of Asian or African descent. Certain traditional healing methods like coining or cupping can leave red marks or bruises on the skin. Some cultures use citrus or vegetable juices on the skin for healing as well. When exposed to sunlight, this can cause a reaction which looks like a redness or burns and may be mistaken for an injury as well. Some signs might suggest sexual abuse can actually result from other causes like poor hygiene, skin irritation from cleaning products, or poorly fitting undergarments or various infections. Suspected abuse cases often trigger strong emotions in EMS and healthcare providers. These emotions can begin to interfere with patient care and may worsen the situation for the patient. Remember, the first priority is safety of the emergency responders, and the second priority is to provide the best possible care that we can for the patient. This includes life-saving interventions and quick transport to a healthcare facility. If time allows, we can conduct a thorough assessment that covers the history of the illness, head-to-toe exam, and relevant medical and social history. Balance the need for fully exposing the patient for an examination with the respect to and need to protect their privacy, especially if you feel like they may have already been traumatized. Do not assume who the abuser is or the exact circumstances. Remember, the caregiver present may also be a victim of the abuse or violence. Use careful judgment about whether to allow a parent or caregiver to stay with or accompany the patient to the hospital. Always remain non-judgmental when caring for suspected abuse and neglect cases. Patient care reports and related documentation may be reviewed by law enforcement, social services, and court officials. Errors in documentation can damage both the credibility of the report as well as you, the paramedic, so make sure that you get those reports accurate. Document all physical findings clearly. Note if any part of the assessment was not completed or if it was delayed and why. Use objective descriptions and precise measurements whenever possible. Record the timing or the time frame of injuries or events. Changes in the report timing over time may support suspicions of abuse or neglect. Avoid labeling anyone as the victim or the perpetrator in your documentation. Always cite specific sources when recording the history of the present illness. Do not take photographs unless your EMS agency has a formal policy permitting that sort of thing. Healthcare professionals must report suspected child abuse and neglect by law. EMS personnel who fail to report suspected child abuse may face civil, criminal, or regulatory penalties. Many states also require mandatory reporting of abuse involving older or incapacitated adults. Reports are made to state or government social service agencies, which may be called Adult Protective Services, Child Protective Services, or similar names. Most states have a central hotline for reporting abuse or neglect. These agencies review reports and decide if an investigation is necessary. Investigation rates and interventions vary widely by state, from family support to immediate removal of the victim. Law enforcement often becomes involved in these cases. Their role includes intervening when a child or a vulnerable adult is in immediate danger and investigating potential crimes related to abuse or neglect. EMS providers may need emotional support after handling a suspected abuse or neglect case. All right, let's move on to talk about some patients with terminal illnesses. A terminal illness is simply a disease expected to cause the death of that patient within 6 months, as confirmed by a physician. These illnesses may last for years, with the patient's health fluctuating or steadily declining. Common terminal conditions include cancer, heart failure, pulmonary disease, liver failure, Alzheimer's, ALS, Lou Gehrig's disease. Many patients choose to avoid uncomfortable, invasive, or minimally effective treatments for their illness. Patients may also decline aggressive treatment for other conditions that might otherwise be treatable. When caring for these patients, be ready to modify or withhold life-saving interventions, and make sure that you provide compassionate, understanding, and sensitive care in these situations. Some patients with terminal illness continue aggressive treatment, hoping for a rare opportunity for recovery. As the illness progresses, many shift to comfort or palliative care, focusing on improving the quality of life and not so much the length. In palliative care, medical treatment continues, but aggressive, invasive, and uncomfortable procedures stop. Patients often still receive pain medication, oxygen, fluids, fever treatments, and antibiotics. EMS is typically called to provide supportive care for these patients. Patients and caregivers often know the best way to handle sudden increases in discomfort. Pain assessment and management are usually primary tasks for EMS. Assess pain using methods suited to the patient's age, communication ability, and cognitive function. Obtain a history of the patient's pain medication use, its effectiveness, and any side effects they've experienced. Terminally ill patients may use pain medications, transdermal patches, or self-administered pain management devices. Patient assessment should include level of consciousness, vital signs, medical history, and pain medication history. Following standard protocols or contact medical control before administering pain medications to these patients because they may already have taken a significant amount before our arrival. Hospice treatment typically helps patients maximize the quality of their remaining life. It provides social and emotional support, and hospice treats discomfort using both medication and non-medication methods. It helps patients and families cope with the approach of death. Advance directives, as mentioned earlier, are signed by the patient or a surrogate decision maker. They guide the healthcare providers on medical decisions when the patient cannot make those decisions any longer. Patients who have decision-making capacity can revoke a previous advance directive. Contact medical control if there's confusion about the documentation or if a surrogate decision maker contradicts a written advance directive. Do not resuscitate orders are physician instructions to withhold some or all resuscitative efforts during cardiac or respiratory arrest. DNR orders can be general or very specific, which methods should or should not be withheld. Some states require a specific DNR order form to be presented to EMS. Other indicators of DNR status may include wristbands or bracelets. EMS regulations may determine whether a DNR status symbol alone is enough to withhold resuscitative efforts. Care for bariatric patients. This is an increasing amount of patients that we deal with almost on a day-to-day basis. They used to be a rarity, now they're pretty common. Of course, bariatrics is the medical specialty focused on preventing and treating obesity. Obesity results from a mix of lifestyle, genetic, metabolic, and environmental factors. Obesity can cause or worsen heart disease, stroke, diabetes, hypertension, some cancers, and asthma as well. Obese patients are more prone to physical injuries and various musculoskeletal problems. Routine procedures for obese patients are often very complicated. Airway management is more difficult due to larger tongue, bigger head, and limited neck mobility. Bag mask ventilation may not work well when the patient is lying flat. Using a ramped position with pillows, blankets, or commercial devices can help improve airway management. Reduced respiratory reserve shortens the time available to secure the airway before hypoxia begins to set in. To avoid intubation, patients often require bag mask ventilation with PEEP, CPAP, or BiPAP. Large neck masses can make it hard to find landmarks for placing an external jugular IV or performing a surgical cricothyrotomy. Standard intramuscular needles may not be long enough to reach the muscle through the thick layers of fat. Medications that are fat soluble may be absorbed and distributed differently in obese patients. And listening to heart tones and lung sounds can be much harder because of the thick abdominal and chest wall tissues. There are a lot of transport challenges when it comes to bariatric patients. Two-person EMS crews often can't safely or effectively move very heavy patients, and extra help is typically needed. Then you add into that small spaces, narrow stairs, things like that, makes the process of moving someone much more difficult. Extremely heavy patients might exceed the weight limits of stretchers, backboards, or stair chairs. Planning carefully, using proper lifting techniques, and getting enough help are the main keys to preventing injuries. EMS agencies should also have gear designed for safely transporting obese patients. Some ambulances come with special winches, stretchers, and ramps made specifically for bariatric patients. Using larger blood pressure cuffs, longer needles for injectables and IOs, and specially sized cervical collars can help to improve care. All right, so let's talk about care for patients with communicable diseases. And of course, these diseases are infectious agents that can spread from one person to another through different ways. They can range from mild or unnoticed to life-threatening within days or weeks. Always use safety precautions and wear the right protective equipment when caring for these patients. These patients often come with emotional and social challenges affecting not just the patient, but the family and loved ones around them. Some communicable diseases are linked to lifestyle choices that society may not accept, which can lead to discrimination, stigma, threats, or hostile behavior towards the patient. Paramedics must always show respect and protect the patient's privacy, avoid making assumptions, or using stereotypes that could harm the quality of care. All right, so let's talk about some medical technologies out there in the pre-hospital setting. Nowadays, many patients with chronic illnesses use invasive or life-sustaining medical devices at home or in long-term care facilities. These patients are often cared for by a mix of caregivers, including family members, unlicensed caregivers, licensed non-professional caregivers, licensed professionals, and any combination of these. Family members are often medically knowledgeable and can be one of the best resources for patient information and care instructions. Medical devices and adaptive equipment encountered during EMS calls or patient transports can either make care for them easier or much more complex. You may have some need to troubleshoot these devices and in order to be able to provide protected or the most effective care. Tracheostomy tubes serve as a long-term substitute for endotracheal tubes and are used when patients require ongoing long-term ventilatory support or the need for frequent suctioning of their airway. Unexpected loss or blockage of a tracheostomy tube might or might not create an emergency. Some patients can tolerate short breaks in ventilatory support without any kind of immediate danger, while others rely completely on their ventilator, so losing it can be a true life-threatening event. In cases of severe upper airway blockage, healthcare providers can place a tracheostomy tube quickly to restore breathing. However, it's important that you understand that there's some training that goes along with this. A tracheostomy tube goes through an opening in the front of the neck and directly into the trachea. Patients can't speak unless the air is allowed to flow around the tube and through the voice box. The tube bypasses the nose, which normally filters and warms the air. Because of this, patients need humidified and warmed air whenever possible. Frequent deep suctioning is necessary using the right size suction catheter with these patients. The outer part of the cannula is the larger tube that goes from the neck into the trachea. It has a flange to keep it stable on the skin and is secured with ties or straps. The outer cannula may have a cuff like an endotracheal tube, which may be important for bag mask ventilator or bag mask ventilation or ventilatory support in adults. The inner cannula fits inside the outer one and can usually be removed for cleaning. It has a 15 millimeter port that connects it to the bag mask or ventilator, so it's a standard sized port. The arbitrator is a solid round plug used only when reinserting the outer cannula if it comes out. When doing mask to mouth ventilations on a patient with a T-tube, the arbitrator is inserted to prevent air from escaping through the tracheostomy. So typically the patient will have all of these components there and available, in case of an emergency. But sometimes that the main part of that thing comes out, the outer cannula comes out, and the airway or that opening will begin to swell relatively quickly and they struggle getting it back in. So it can be challenging. Fine straighted tubes have holes or openings in the outer cannula or both in the inner and outer cannulas. These openings help the patient speak, breathe, or clear secretions from the upper airway. These types of tubes are used for patients who are being evaluated for tube removal or who need intermittent ventilatory support. So these are kind of a temporary thing that, maybe towards the road of getting that removed. Of course, it's very important to deflate the cuff before capping a fine straighted tube. So when necessary, when you're dealing with these tracheostomies, be willing to accept help from patients, family members, or caregivers when evaluating, using, or troubleshooting a tracheostomy tube, because they have a lot of experience with these. Routine care is going to include keeping the stoma clean and dry and suctioning that thing periodically. We can troubleshoot these devices using the DOPE acronym. So DOPE stands for displaced or disconnected tubes that can sometimes end up in a false passage after removing or reinsertion. You can check for a false passage by gently inserting a suction catheter into the tube. If the resistance is just beyond the tube's end, suggests it's a false lumen. If it happens, remove it and carefully reinsert the outer cannula. Continuous end-tidal capnography during transportation helps detect unexpected dislodging or disconnection. Obstruction can be cleared by removing the inner cannula and suctioning out the mucus plugs. Combined suctioning with mechanical ventilation is needed. If the tracheostomy tube is lost or unstable, carefully insert a proper sized endotracheal tube into the stoma to maintain that opening. Use tools like a bougie, a gloved finger, or a hemostat to help guide placement. Confirm correct placement by checking end-tidal CO2, breath sounds, chest rise, ventilation compliance, and of course clinical improvement. Remember, pneumothorax and equipment issues can also cause other problems to arise. So for proper suctioning and cleaning of a tracheostomy tube, refer to that skill drill in this chapter. It's the first one in here. Skill 46.1 will give you a breakdown of how to perform a tracheostomy suctioning. All right, that's the end of part 1. And I'll see you guys back in part 2 of, chapter 46. I forgot what chapter we're on. We've been through so many. See you back in part 2.